So in this video, we're going to be talking about the active straight leg raise, which is a test to look at how well someone is performing load transfer from the lower extremities through the pelvis and the core. And there are some things from this test that are definitely in the literature and some things I've kind of extrapolated to use in my clinical practice. So I'll try to differentiate between the two. So first of all, with your patient, you're gonna ask your patient to raise their leg about 4 inches from the table, one at a time. You as the clinician are gonna observe, how is this patient accomplishing that movement? Do they look fairly stable? Are they rotating? Are they holding their breath? Are they arching their back? Do you see some abdominal bulging? So it's not just what the patient is doing, but also what you're observing. So while the patient lifts one leg, you're observing, but you're also asking the patient to rate that difficulty of raising the leg 4 to 5 inches on a scale of 0. That was so difficult, I couldn't do it, to 5. That was super easy, no problem. So go ahead, Lisa, lift your left leg right up to touch my hand. Good, and then put it back down. How did that feel for you on a scale of 0 to 5? 0 is super easy, 5 is super hard. 0. Okay, perfect. And now we'll raise the other leg that same way, and then lower it. And what did you feel there?
Like a 1.
Okay, so right leg was a little bit harder. She'd have a score of a 1 out of 10, which is not clinically significant. So if Lisa was my patient, I'd be like, great job, you look really symmetrical. We're just gonna move forward from here. But say that right leg was a 5 and the left leg was a 0. Then I want to see where can I put my hands on her body to help that right leg move better. And basically, you know, what we think is the hands are just creating an increase in neural proprioceptive feedback to maybe improve some of the motor performance. So I like to do that. This is Jen Vandebeck. I like to do that in 4 different places. So the first place I go is the pelvic girdle. So I'm going to take my hands around her bony pelvis, and I'm just gonna squish her medially. I'm gonna apply a medial force. Lisa, is it okay if I touch your pelvis? Sorry, I didn't ask. So I'm gonna squish your pelvis. Go ahead and just lift that right leg again. And did that change your perception? Did that make it easier, like a lower number, harder, a higher number, or no change?
No change.
No change. So then I can say, okay, she's doing good with stabilization at her pelvis. Let's look at the lower fibers of the TA. Lisa, could you expose your belly for me? So what I want to do now is take my hands on the inside of the ASIS, where I'm going to get those lower TA fibers, and I'm going to create a medial smush with my fingers on her skin to shorten some of those fibers of the lower TA. So is it okay if I touch your belly? Mm-hmm. So I find her ASIS, and my hands are just like this. I'm going to squeeze her abdominal tissues together. So I'm not pushing down deep, I'm just squeezing to the midline. So go ahead and lift that right leg again. Easier, harder, no change?
No change.
Okay. So now lower fibers of TA are doing their job stabilizing. I don't need to worry about them. Now I'm gonna put my hands in a place where we're getting both the rectus abdominis fibers and closing rectus for approximation of any diastasis recti, or I'm also probably getting some of the middle TA fibers. So I'm going to come along the lateral margin of the rectus abdominis, I'm going to sink into that tissue and pinch it towards the midline, above and below the belly button. Go ahead and repeat that right leg. Did that make it any easier?
No change.
No change. So rectus abdominis, middle fibers of TA are doing their job. Now the last place that I'm going to look, and this is where I think I've extrapolated my own interpretation of the data here, is her rib cage. Okay, so when I do this on exam, it's okay if I expose this part of you, I take my thumbs on the xiphoid process and I align my thumbs along the medial rib cage. And I just take a minute to check the angle of the ribs. So we want that angle to be about 90 degrees. If the ribs are a little bit wider, I might be more curious about how this part of the testing is gonna come out. So Lisa's ribs are just a smidge wider than I would expect at 90 degrees. So I'm gonna take my hands on her ribs. I'm gonna bring her ribs medially and then posteriorly. So I'm bringing her in and down. I'm really stabilizing now through the upper fibers of the transverse abdominis, through the rib cage, and I'm encouraging a little bit more external oblique activation with stability. I'm putting those muscles in a shortened position, which will make them more effective. And then I'm gonna ask Lisa to raise her right leg. And does that feel lighter?
It's easier.
Finally, we found something for Lisa. And so this is the rarest example. This is the rarest pattern that I find. I find most people will have the most positive changes with TA or RA, then pelvis, and then upper rib cage. So let's talk about what these findings mean. So if someone had an easier time with pelvic ring stability, I might need to look deeper at what's happening at the pelvic floor and what's happening at the hip muscles. If they have lower transverse abdominis activation pattern, then I want to look more at how TA is firing. If they do best with RA approximation, I might want to look more at diastasis training. And then if someone has this upper rib cage pattern, what I would teach them is how to engage and correct for lower rib cage in like poor mechanics, basically. So for Lisa, she's laying here. You can see her ribs are in a little bit of a flare. I'm going to teach her. Okay, keep your hands there. That was good. So Lisa, can you find muscles that draw these ribs in and down? Good. And what does that feel like for you? Hold them there and see if you can still breathe with your ribs in that in and down position.
It's hard.
It's hard, right? So these are some of the activities I might do. Go ahead and bring your arms up to the ceiling. I want you to keep your ribs in and down. And then take your right arm extended out by your ear. Keep your ribs in and down. Good. And then you're going to exhale as you move your hand by your ear. Keep your ribs in and down. So this is how I might train kind of like an upper core patient to connect with rib cage positioning and upper abdominal stability. Go ahead and do the other side. And I do have a YouTube video on this as well. It's called Thoracic Stability and Mobility. You can check that out. And now do both at the same time. So that just gives Lisa a little bit more proprioception on how to find these muscles to stabilize at the upper rib cage. Thanks so much. I hope you can employ the active straight leg raise technique to understand your patients.